It's a little bit like the situation with thickening fluids. So it's quite a well-established practice. Yet we don't have a definitive and randomised controlled trial that demonstrates its safety and efficiency in any population.
Hi, Jackie. It's great to meet you, and thanks for taking the time to come on the podcast. Would you like to briefly introduce yourself?
Hi, so I'm Jacqueline Benfield. I'm a speech and language therapist and a clinical academic. So and how that works is I am a clinical lead speech therapist for stroke in Derby, and I work 3 days a week doing that, which I have leadership responsibilities as well as seeing patients in the acute stroke and stroke rehab wards. I'm also a researcher, and I've got an interest in post-stroke dysphagia, the street screening and assessment of swallowing, as well as dysphagia rehabilitation. And I'm currently in the first year of NIHR clinical lectureship. So that's like a postdoctoral fellowship, continuing with research into swallow strength and skill training in acute post-stroke dysphagia.
That sounds really interesting. Together with Rebecca Julia, you have conducted a mixed methods research study on the use of oral trials in dysphagia management. In the conclusion section, you write, "The results begin to outline the complexity of both defining and delivering oral trials." So maybe you can start defining what oral trials are.
Sure. When we started the project, we went to look for a definition in the literature, and actually we couldn't find one. So we sort of had to define oral trials for the purposes of the projects that we were doing. So we defined it as a dysphagia management approach whereby specified limited amounts of oral diet or fluids are recommended for those at risk of aspiration or choking if full amounts are taken orally. There's sort of assumption that there may be a sort of a degree of risk involved in these trials, but less so than if the patient were to be having sort of full amounts. However, like I said, it was a definition that was proposed by ourselves, and it may well be that there are other people who use oral trials or recommend oral trials that have a different definition or even call them something differently. And even sort of within when we were doing the research, which we'll come on to, there were some different ideas from the people we interviewed about kind of what that included. Because I, for example, would have thought that these were different to things like tastes for pleasure, where a patient may be eating and drinking small amounts with accepted risk alongside sort of long-term non-oral feeding. That was our definition for the purposes of the research.
Okay, just one quick question about the definition. So does it mean that patients who are eating and drinking orally, maybe only specific consistencies, they also additionally get oral trials for training purposes or therapeutic purposes, right?
Yes, yeah, and that's again we'll come on to that, but we found that as well, that actually they might be on a full oral intake of something that they're potentially deemed to be safe on, but then having small amounts of something else where they're maybe not safe on to have full amounts of, but may be able to manage small amounts sort of more safely with less risk.
Yeah, okay, got it. Thank you.
That's really interesting that this is something that I think most clinicians actually use every day in their clinical practice, at least if they're in the acute setting. And we don't even have a definition of what it actually is. So besides the lack of definition, what do we actually know about oral trials from the literature so far?
Yeah, like you said, we think that they're being used. In fact, we know there's some evidence that they're being used. There's evidence that they're being used in the UK, in Australia, in the US, India, and other countries in Europe. And we know that because it's been documented as a therapy approach in surveys that have been conducted by the researchers. For example, Archer and colleagues found it was a common as a rehab tool in a survey in acute stroke, and then a similar survey by Jones and colleagues in Australia found that trials were used in that way. But also it's included as a scale on some of the outcome measures. So for example, the functional oral intake scale, FOIS, the TOMS, therapy outcome measures, and the DSRS, the dysphagia severity rating scale, all of those include either a kind of scoring system or a level on the scale for oral trials. So we know that they've been used in the UK and the US, or been sort of founded, I guess, in those countries. So they're being used. And then also, since the work that Rebecca and I did, Lisa Everton and colleagues looked at the data from the STEPS trial, which was the pharyngeal electrical stimulation randomized controlled trial, and which used the dysphagia severity rating scale, and found that researchers were marking off on the scale. Some of the data showed that they were using oral trials, and that was mainly in the UK, but there was also sites in Denmark, Spain, Germany and France. So they're being used, and she also kind of looking at that data found that trials are being used so that usually there's specific consistencies documented. There's limited amounts, and they are specified limited amounts are being used. Also, bolus size is specified in oral trials. For example, teaspoons versus sips, and they can be delivered by the speech therapist or somebody else from the MDT, multidisciplinary team. And they may be used in conjunction with another strategy, such as effortful swallow. So that's what sort of Lisa and Everton and colleagues found, that looking at that data, that it showed that that's how trials were used.
Yeah, and just one more question. So this was mainly on the rehabilitation, so used as a rehab tool, you said. But would we call it oral trials as well if we use it in the assessment? And do we have any data on that?
We haven't focused a lot on that, I don't think.
Okay.
I think that's slightly different, though. They're just sort of part of an assessment tool, I guess. But I guess it's still important that we are trialling different consistencies and different amounts within our assessment, as well as other strategies or manoeuvres and things like that. But we were focusing more of it as a recommendation for that's carried over outside of assessment. And again, we don't know really if people are doing it as a rehab. But in some of those examples, for example, in the surveys, it seems that they are using it what options for rehab are you offering, for example, was asked in these surveys, and that was one of the responses. So there are a couple of other programs that are used. For example, the McNeil Dysphagia Therapy Program, which does use small amounts of different boluses, volumes and consistencies, but they pair it with other aspects of therapy. So, it's about intensity and a specific swallow pattern, for example. They use the volume and the consistency as a sort of challenge, as a weight, as a to be able to challenge the swallow as a rehab tool. So it is more than just recommending that someone has some small amounts of something a few times a day. It's very much paired with the whole package, I guess. But yes, we know it's being used. We know it's being used in rehab. We know a little bit about how they're being used, but nothing about safety or effectiveness, or even, like you said, a definition or any evidence around why particular things are being recommended and not, why specific amounts versus consistencies are used. But there's very little around the kind of detail.
Okay, thanks for the overview on the current state. So you started your own research within this topic. What was the aim of it, and why is it relevant?
I think the overarching aim was really to find out whether they were effective. Are they helping our patients? And then sort of that became the discussion around, well, are they safe? And actually, when we sort of started looking at the literature, the building blocks aren't even there to sort of start off. I think we sort of then started from thinking about it from the beginning. We need to look kind of understand really a little bit more about what they were as such, and to start off with. So the first was just to start by describing in one hospital setting how oral trials were used. So by looking at kind of the hospital database, and secondly, why oral trials are used. We looked at then interviewing speech therapists, but obviously it was restricted to one site, and within the sort of time and resources, it wasn't intended to try to represent kind of knowledge or practice elsewhere. It was hoped it would sort of start the conversation for further research to be conducted.
Yeah, it seems like a really good starting point. So in your research, what design did you apply? Maybe you can briefly outline in the first and the second study what you did.
Yeah, so the first one was more of a kind of quantitative approach. So it was an observational study called a cross-sectional database study. So really it was just looking at kind of one time point where the data was pulled out from the database on patients that were on the current caseload, and asking some questions around, are they on oral trials, are they not on oral trials, and some information about their demographics and diagnoses, ward or department they were under, who had been involved in their assessment, those sorts of things. So that was more the quantitative part. And then the qualitative part was using grounded theory approach and in a series of focus groups with speech therapists who are working in that hospital setting that we knew already uses oral trials. Yes, that was just to find out a bit more depth to kind of the clinical decision making around trials and the rationale, the reason, the why are they using trials, rather than just the kind of who was on trials and how they were being used.
That's a really interesting study design. I think the mixed methods approach has so much to offer and so many possibilities to look at one topic or at one question from different angles. Okay, so what did you find out in your observational study?
Yeah, so like I said, just looking at the database, at that time point, there were 118 patients on the caseload of this particular hospital, and 23 out of those 118 had been on or were on oral trials at some point in their stay. And currently there were 13 who were on oral trials. Having a neurological diagnosis was the key factor in predicting if a patient was on oral trials or not. I think goes back to this idea of it being used as a rehabilitation sort of tool, that actually these are patients who are in an acute setting having a new neurological diagnosis and potentially undergoing rehab. So that was kind of the main sort of key factor. And then collected data on how all trials were being recommended, what sort of recommendations were there. So again, similarly to what Lisa Everton found in the STEPS data, the trial data, there were specific consistencies being recommended. So that ranged from level 0 on the IDSI, so thin fluids, up to level 7, again, the sort of regular diet on the IDSI framework. So specific consistencies, specific bolus sizes were defined in the recommendations. So for example, with fluids, it was teaspoons versus 6. There were specific quantities, so sometimes there was 3 teaspoons up to 100 mils of fluids, or 10 teaspoons of diet to sort of half meals at times. And there were specific frequencies of how often those trials were to be delivered. So it might have been one up to 6 times a day. There was such a variety of all of these things. And similarly, there was sometimes the trials were delivered by speech therapy, and at times the trials were delivered by other members of the multidisciplinary team. And then, like you mentioned earlier, there were 2 patients who had full oral intake of certain consistencies, but then they had oral trials with other consistencies. So, like you said, it's not just about people who are sort of nil by mouth or on tube feeding or what have you.
That's really interesting. And one question in between. So those were on a specific consistency, and then they had other oral trials with another, maybe more difficult to swallow consistency. But you said that one or some patients were on, for example, IDSI level 7, so a normal oral diet. And how were those incorporated as oral trials?
So, for example, someone might have been on a level 5 or a level 6 diet, and they were doing oral trials with level 7 textures.
Okay. But they weren't on level 7 diet.
The oral trials that were recommended were between level 0 and level 7.
Okay, thank you.
And did you have the possibility to look at the patients from the neurological group? Could you find any subgroups who are especially prone to be on oral trials?
I guess it was a really small data set. We looked specifically at those that were currently on oral trials, so it was just 13. So it would be really difficult to kind of try to break that up. But it's definitely something that we'll look at later, something that, in future studies. And actually in the interviews, which I'll talk about in a moment, I'm sure, we also found that may well be that patients who are kind of have an acquired, not like a deteriorating neurological condition as such, more of an acquired kind of brain injury or stroke, that kind of thing. And actually it came out that there wasn't consistent documentation on the reason why oral trials were recommended. Only 2 were documented that they were for rehab. Doesn't mean that they weren't, it just it wasn't documented. And the same, that idea that maybe these trials, there may be some risk associated, but only sort of, again, 2 or 3 of the documentation showed that there was a level of risk that had been either discussed or accepted by the kind of medical team or the patient, I guess.
So after this observational study, you conducted a qualitative study with focus groups with speech and language therapists from this one hospital. Can you maybe briefly outline what you did in this part of the study?
Yeah, so all of the speech therapists working at the site were invited to interview. Those groups were sort of facilitated by Rebecca, and we developed generally structured interview questions, or focus group interview questions, to start to try and introduce and to understand why they were being used, their experiences of offering them, any barriers or facilitators behind the use of trials. Yeah, so lots of different kind of questions. And those interviews were all recorded and then just transcribed. Those transcriptions were then coded by 2 different researchers to look at any themes that were present, or that could be identified.
So looking at your results, you found 3 main themes. Maybe we start with the first one. It was called Delivering Oral Trials Requires a Whole Team Approach. So what did the participants mean by this?
So trials are usually recommended by speech therapists, but at times they're also agreed by medical teams. They're carried out by nursing teams, which includes nurses, nutrition assistants, healthcare assistants, and they're supported by the hospital environment. So it is a whole team approach. It's not just that it's something that we do in our therapy sessions and nobody knows about it. And then speech therapists had sort of more confidence in nursing teams that were trained or had specialist skills. And also, it wasn't just a kind of them conducting it and carrying out the trials, it was also the feedback. So if they were done well, the speech therapist said that they used the feedback from the nurses or the documentation from the nursing teams to help understand if the trials are working well, or they need to be changed, or there's risks that we hadn't or that hadn't been predicted, or those sorts of things. So it's a two-way and multi-team approach. And then they also took the skills and the opinions of the MDT team into account when making clinical decisions around oral trials. So it depended on kind of who might be delivering the trials in order to kind of how they made their recommendations about what specifically to give and how often.
Yeah, and that's really one advantage I feel of oral trials, that it's relatively simple to deliver. So the whole MDT could help us SLTs in delivering it, because we only see the patients like once a day if we're lucky for an hour or something. So, and then looking at the principles of neuroplasticity, it's really important to have a high intensive training, especially in an acute stage. So that's really something pretty helpful, I think. But then sometimes it doesn't work out this way. So I guess it's an advantage, and then also sometimes it can be a challenge, I guess.
Yeah, absolutely. Yeah, definitely. Talked about choosing not to recommend trials in with certain patients because of the kind of MDT situation, versus in other cases, definitely doing that because they had a good support sort of set up there.
Yeah. So what can we understand by the second theme, SLTs vary recommendations based on patient and environmental factors?
Yes, this was kind of the things that came across were things like the patient's length of stay and kind of whether they were going to be in hospital for kind of rehab, or it was an acute stay for them to get home as quickly as possible because they had an acute illness and they were leaving. We found that patients were more likely to be on trials if they were in the neurological setting, but it wasn't just exclusive of that. And obviously, the therapy teams work with patients on acute wards, which might have come in with an acute infection, but who have dysphagia or have, and kind of because they're medically unwell, have a dysphagia. So the therapists were talking about in these interviews or in these focus groups that some patients who maybe have dementia or other kind of chronic conditions might not be considered for oral trials because actually the plan is to get them home as soon as possible, or because they're not suitable for non-oral feeding. And actually we just need to, it's about thinking about feeding at risk. So it's getting those patients onto full amounts. And in those cases, they're sort of not in hospital for rehab as such either. So they're not being offered at, trials, even if they're on full amounts, they're not tending to offer trials of sort of less modified consistencies, for example, in those cases. So that sort of affected whether they were offering trials or not. They also said that the availability of certain foods might affect the sort of trials that are being used, or kind of the staffing as well on the wards. If there's reduced staffing, and it may only be recommended sort of in those meal times, whereas if there is additional staffing, like these sort of, for example, people who specifically help with feeding on certain wards, they might be able to offer them more frequently. And again, patients' allergies or preferences were also having to be taken into consideration. So there was lots of things that impacted on why they were offered. Also backed up the research, the other project, to say that most of the time they were being offered to patients who had potential to improve, such as those with an acute acquired neurological condition, or those who have been in critical care and had a period of perhaps no by mouth for a long period of time and were unable to sort of commence oral intake straight away, and they were kind of decompensated.
Yeah, so the third theme was oral trials as a holistic approach. What does that mean?
So this was sort of almost the kind of rationale around why they were offered. I think, again, it's not clear. We don't know from the research why they're being offered. So it was really useful to hear different people's opinions. But what the speech therapists said in these groups were that they were beneficial as they helped to maintain oral hygiene. The idea that they promoted swallow rehab. There was an indication that they align with the principles of neuroplasticity, such as use it or lose it, use it and improve it. And obviously being kind of trials of food and fluids, things that we actually eat, and we do eat and drink and we do swallow, they're specific to the task that you want to improve. So they sort of fit with those principles. And also therapists said that they were practical to deliver regularly compared to other dysphagia interventions, whereas, for example, like you said, speech therapists perhaps might be the ones delivering more specific therapy exercises, but people who are trained in supporting and feeding patients with dysphagia could be delivering oral trials. So they're more practical to deliver. They also felt, again, that it appealed to patients more than exercises, because it was something more interesting than putting your chin down against a ball or doing an effortful swallow with saliva, for example. And then they also felt that it contributed to quality of life. So it was motivating, it gave patients enjoyment, and it also gave patients hope for recovery, hope for improvement, or hope for sort of normality getting out of hospital. The idea of being holistic, it wasn't just about, one thing. It wasn't just about quality of life. It wasn't just about rehab. It wasn't just about oral hygiene. It was lots of different, it could be targeting lots of different things.
That makes totally sense. And it's really interesting to look at it in more depth and actually to reflect on it yourself, because I feel, at least that's my point of view, that oftentimes you just do it because you feel like it helps, but you don't really think about why actually it might help.
Yeah, absolutely. I definitely, and I think people didn't actually specifically say, for example, on the rehab side of things, that it was, fits with the principles of neuroplasticity. It was just examples that they gave, So, for example, they said, if you're not swallowing, it means you're not going to get any better.
Yeah.
Those sorts of ideas. So definitely, interesting, really, and not just about rehab. It was about motivating, and that opinion that doing something like that is more motivating than other exercises. And I guess we don't. Again, like you said, we don't really know whether that's the case, actually what patients think about that. So that would be interesting to find out, wouldn't it?
Yeah, absolutely.
Okay, let's move on to the discussion. In the discussion section, you mentioned 2 points that I found very interesting. So the first one was that the advantage of oral trials based on the participants' views is that it can be used flexibly to address the individual as a whole. So again, also the holistic approach, adapting the approach in consideration of a range of factors. This makes it an easy to use approach. However, conducting research on it makes it quite difficult. Do you have any suggestions how we could approach this in further research studies, or do you have any plans for the future with your research?
Oh yeah, really good questions. It is really complicated. I think it's a little bit like the situation with thickening fluids. So it's quite a well-established practice, yet we don't have a definitive and randomised controlled trial that demonstrates its safety and efficiency in any population, but it's being used, and there's a lot of there's sort of differing opinion in whether it should be being used, whether they should be being used, and whether how effective it is, and obviously that's across different populations. And it's the same sort of here. It's already established, so it's really hard to go and do a sort of standard, randomised controlled trial. If new speech therapy interventions had to go through the same process as testing medicines, then we would have better evidence, because you can't just start using a new medication, with patients unless it's been fully tested all the way through. And in some respects, I think we should be treating speech therapy interventions like that, because there could be some things that are harmful. Thickened fluids, or for example, oral trials may well have some risks associated to them, which, we're not aware of. So I think ideally it would be good to go through those systems, but because they aren't medications, because we can just come up with an idea and try it, it just makes things a lot more complicated. I know they are used a lot, but it's not clear whether they're used everywhere. So I've certainly worked in some services that haven't used oral trials because of concerns about risk, or having teams around that aren't, there's not confidence in the teams that could be delivering them, or they could be done with speech therapists in sessions, but that's only very limited. So there may be some questions that could, you could look at kind of safety and efficiency in some of those sort of settings. And we do need to look at safety as well as effectiveness. There may well be an increased chance of getting pneumonia in patients who are on oral trials that we're not being able to pick up if it's a small risk of increased pneumonia. So I do think we need to be looking at safety, and also kind of thinking about how oral trials are used in different settings with different client groups, but also different services. So, further kind of interviews, focus groups or surveys, I think would be really important to gather a bit more understanding about what's happening in different settings for different people. And, there are kind of research designs that can be kind of like case series and kind of N=1 designs, where it's not something I've used, but I've certainly tried to incorporate, whenever I've done any sort of systematic reviews, tried to incorporate those sort of trial designs, but it's not something that's being used very much in any speech therapy research. Certainly there's a lot of case studies, but they're not always using the robust methodology where we can really understand kind of, if there's any change to baseline, so you can use things like multiple baseline measures and certain statistical approaches to really be able to kind of look whether oral trials have an impact on certain, patients individually. So that's things that actually clinicians could be doing, is be collecting data. And in terms of what we should be doing in terms of clinical practice at the moment, it's a really difficult one. I think I continue to use them despite kind of having this, doing this research and continued awareness, because when I'm suspecting that there's risk, some element of risk involved, I'm sort of ensure that, patients and families and teams are aware of that. We're experts. This is our area. I don't think we should be stopped doing something just because there's a lack of evidence. At the moment, I'm not got anything planned, or there's lots of ideas, and I don't really have much capacity to do something myself at the moment, but would be very happy to support others if to seek some funding or to support a project if someone else wanted to do something.
Okay, so to our listeners, contact us if you're looking for a dissertation project. Do you have any recommendations for us as clinicians, what we can do until more evidence is available? How can we best decide when and with whom and how we can use oral trials in our management?
Using outcome measures is really useful in any kind of setting. So you can be looking at, trials and keeping, being aware of risks involved and just, monitoring them. Maybe documenting the rationale or thinking about the rationale. Why are you doing this? And maybe documenting it so that, it's clear to yourself, and maybe there'll be some research in the future that will be looking at your notes. But also, it's sort of, with everything we're doing, we should have a rationale for, and actually, sometimes we do ourselves short clinically. We don't sort of always describe, the clinical decision making we're doing that, really makes our profession, makes us professionals, makes us specialists. So I think it is useful to say, we're doing this as we think this is going to be an approach to help at least maintain a swallow, if it's not going to improve a swallow by practice and challenge of doing so with oral trials. Watch this space.
So there was consensus that an instrumental assessment was not considered necessary prior to beginning oral trials. Why not? And what are your thoughts on this? Considering these are patients, like you said, who are at risk of aspiration.
Obviously instrumental assessments are really important for identifying impairment, planning therapy, perhaps specific recommendations for complex presentations. So obviously, they're used to help define that for any new dysphagia or persistent dysphagia, but we can't be doing an instrumental assessment for every decision that we make around changing a patient from one recommendation to another. It's impossible. Patients would be exposed to a great deal of radiation, or it's not possible or for fees, for example, wouldn't the time involved in doing those assessments, it's not practical for us to have to use those for every single decision that's being made. And I think for the same for oral trials. So for example, if a patient was started on and were doing really well from a video fluoroscopy or from a fees, you couldn't then repeat it every time you needed to change something or increase that amount. It's just not feasible. So we have to trust our clinical bedside assessment, the skills that we've learned and we build, and there's lots of things we've got in place. A, training; B, we do joint sessions and peer supervision and all those sorts of things to try and help build. And there's further courses we go on, and we are specialists in this area, and we have to trust that and be aware of evidence still emerging all the time, evidence around signs of at bedside that can constitute risks or not, and things that we might be over or under assuming. So, I think we have to trust bedside. We have to be up to date with the evidence though, and see what's coming out. I think there are times where perhaps these decisions need to be made with a instrumental assessment. So if someone's, particularly high risk or particularly complex presentation. So, for example, I've had patients where I've thought oral trials have not been appropriate because they seem too risky. And then actually by doing the video fluoroscopy or what have you, you've actually found that there may be a way that they can be on some oral trials safely. So I think definitely there's a place for using instrumental assessment for this. But I think you have to sort of judge also, and trust your clinical skills, and just sort of making sure that everyone's trained up, especially sort of newer people coming through.
Yeah, absolutely. I think instrumental assessments are really helpful and amazing, and it's great that we have them now. But it's also important to not forget about our skills and what we can do without it, and that oftentimes it's also enough to do a clinical bedside evaluation if it's well conducted. Instrumental assessments also only give us a glimpse of a swallow at a specific time in a quite unnatural situation. And
exactly.
It's not only instrumental assessments for sure.
And one of the key factors in assessing at bedside as well, I think, is giving enough, as well as on instrumental assessment. We're all very variable in our swallow from one swallow to the next. So giving enough at bedside and giving enough, on instrumental is also really important to help us. And like you said, if those assessments are done well with, looking at the cranial nerve function, looking at the wider issues of the patient, getting a good case history, conducting trials within that assessment. So trying out different sort of strategies as well. So
yeah, and we're not only variable in our swallows, but also variable in how we actually conduct the assessments. So it's so complex.
Absolutely.
So in summary, what are the pros and cons of oral trials in dysphagia management? And do you have any last or main clinical recommendations based on your experience?
Well, in terms of the pros, I think, like we said, that what's come out of the research so far is they seem to be practical. We think that they can help to improve patients' quality of life they at least help to maintain good oral hygiene and can give, like I said, give patients some enjoyment. They may help to rehab swallow or maintain swallow function. And like we said, they're practical to deliver in an acute setting, certainly. So those are sort of the pros. But in terms of the cons, but there is a chance that those who are on trials might be susceptible to chest infections. There may be also this kind of idea that oral trials, because they're practical and it's sort of easier to recommend, there might be other rehab approaches that are not being offered potentially as well. And we don't have the evidence about whether they are effective or not. They may be, but we don't know. So we don't know how they compare to other interventions either. They may be less effective than other interventions, or they may be more. So there could be a bit of an over-reliance on them. We mustn't ever be lazy. We need to be making sure that we're using our whole toolbox of approaches for people with dysphagia, and not just getting into sort of habits of one approach versus another. I think that's probably a recommendation for clinical practice as well there.
Yeah, we mustn't ever be lazy.
Well, I don't think we are, but it's
no, but it's a really good point, because I haven't thought about this point, that it might seem easier to implement and just to conduct oral trials than other maybe more complex treatment approaches. So and as long as we don't have the needed evidence, we mustn't ever be lazy. I like that.
Absolutely.
Good point. Okay, thank you so much, Jackie. We really appreciate that you took the time to visit us. We hope you, our listeners, enjoyed this episode as well. Let us know what you think. Leave a review or get in touch with us on Instagram at Dysphagia Matters, on Twitter at DysphagiaPcast, or visit our website, dysphagiamatters.org. Thank you so much for listening. Thank you, Jackie, for coming on the show, and take care, everyone.
Bye-bye.
Thank you. Bye.